If you are a physician who is treating varicose veins or a healthcare professional who is concerned about venous problems or even treating patients who needs compression therapy, you are now in the correct place to get more information on this topic. Hi, this is Dr. Aghdasi, interventional cardiologist and venous disease investigator. The aim of compression therapy is to increase support to the calf muscle and to reduce venous hypertension. Compression has been shown to reduce the levels of inflammatory markers found in the systemic circulation. It improves venous pump function in patients with chronic venous insufficiency. In real world, compression is administered more than usual recommendations in guidelines. Actually, data in favor of compression therapy are often weak, and it's mainly due to the poor quality of studies. Compression therapy is recommended for symptomatic varicose veins or more severe stages of disease from CEAP class C3 and above, if even it is asymptomatic. Additionally, compression should be offered to individuals with occupations that require long duration of standing or environmental risk factors for edema. A quick look into physiology shows that in the supine position, the venous pressure will be between 10 to 20 millimeters of mercury. At this point, venous compression by a low external pressure may explain the effect of thromboprophylactic stocking used in a recumbent post-surgical patient. During standing, the intravenous pressure in lower leg vein rises to around 60 millimeters or more, depending on the individual's height. In normal individuals, physiologically after or during walking, it decreased to near 30 millimeters of mercury due to working of the muscle pump and valves. In practical use, compression is divided into three categories based on equipment: 1 stocking, 2 bandage, and 3 pneumatic compression devices. Stockings include knee-length socks and thigh-length socks and provide the user more degree of freedom for self-apply and need less manual skill for use. They are easy to handle only for people with sufficient strength, ability to bend, and without any joint impairment. Compression stockings are classified according to the pressure applied at the level of ankle. It showed that the presence of a pressure gradient with the strongest compression at the level of ankle and the lightest at the top provides the most favorable hemodynamic effect for reducing limb edema. The stockings are divided into 3 classes. Class 1, low pressure stocking with an ankle pressure of less than 20 millimeters of mercury. Class 2, moderate compression, which is between 20 to 30 millimeters of mercury. And Class 3 stockings are high compression stocking with ankle pressure of more than 30 millimeters. Overall, improvement in symptom severity scores would be observed at 1 month after initiation of treatment with these stockings. Further improvements would be noted at 16 months. The second equipment is compression bandaging, defined as the spiral wrapping of up to 4 layers of bandage over the affected limb in order to provide stepwise graduated pressure. The success of this administration depends strongly on the skill of the provider, so sometimes it's difficult to achieve the desired compression benefits. Bandages may suffer from loss of elasticity with time, and washing and also incorrect application can result in treatment delay. In general, compression bandages can be divided into long stretch bandages and short stretch bandages. Long stretch bandages may be extended by 2 times compared to their original length and called elastic bandage, while short ones are less extensible and called inelastic bandage. Elastic bandage generate moderate pressure that are similar during the resting and standing position. inelastic ones provide low resting pressure that significantly increased in the standing position with the help of muscle contraction. Several layers of elastic bandage will create a bandage with increasingly inelastic properties. The same is true when two stockings are used over each other. With inelastic bandage, the initial resting pressure will decrease by about 25% within 1 hour of application. Note that bandages with inelastic material should be applied with much higher initial tension than elastic bandages because of the fast pressure drop. Here I want to highlight the effect of inelastic compression for leg ulcer treatment, which also advised by many experts. In early acute phase of DVT or SVT, also this type of bandage is recommended because of the ease and availability and also lower cost. In acute phase of venous thrombosis, superficial or deep, after inelastic bandage, prescription of a new stocking fitting the leg size when edema is reduced is a wise approach. Other dedicated bandages are adjustable compression wraps and held in place with Velcro. It is inelastic and rigid and is superior to elastic stockings in patients with advanced venous insufficiency. It's also good in limbs with size discrepancy in different parts of the affected leg. Regarding the choice between inelastic bandage and wraps, I want to underline the advantages of wraps over inelastic bandage regarding comfort and ease of use. The third equipment is pneumatic compression devices, which provide precise pressure control and improve compliance. They can monitor and adjust the compression. A wide range of pneumatic compression devices exists and can be classified into three types: fixed with no mobility, semi-portable, and portable. The ultimate solution called smart compression therapy, which maintain optimum pressure levels and enable the user to live a near normal life while wearing the device. This intelligent system would continuously monitor and adjust the pressure in response to the user's activity level. This also wirelessly transmits the relevant compression data to healthcare professionals. Actually, compression therapy was found to be inferior to minimally invasive endovenous therapies, including ultrasound-guided foam sclerotherapy or endovenous thermal ablation. So, a 3-month trial of compression stocking before intervened patients with CEAP class C2 has no evidence for benefit except in special situations discussing later on. For patients with symptomatic varicose veins and axial reflux in the great saphenous vein or small saphenous vein who are candidates for intervention, guidelines recommend superficial venous intervention over long-term compression stocking. This recommendation in anterior and posterior accessory saphenous veins is less favorable. For patients with symptomatic varicose vein and axial reflux in the superficial truncal veins, guidelines suggest compression therapy for primary treatment if the patient's ambulatory status or underlying medical condition are not okay for intervention, or if the patient prefers conservative treatment for either a trial period of long-standing management. Compression therapy has been used to reduce post-operative bleeding, bruising, edema, and pain after thermal ablation for superficial venous strength. Compression is effective in reducing early pain also in patients who underwent concurrent phlebectomies. After thermal ablation, a compression with class 2 compression stocking with eccentric pads over the ablation point is recommended for greatest reduction in post-operative pain. This post-procedure compression in patients undergoing thermal ablation with or without concomitant phlebectomy should be applied for a minimum of 1 week.